Hello, everyone. Welcome, welcome. Just going to wait a little bit here and let people join. Thank you for your interest in tonight's webinar. Hey, Devin. It's good to see so many familiar names and people from all over. My name is Bridgett Wallace. I'm a physical therapist, and I'm going to be talking today about dizziness and differential diagnosis algorithm that I created a while back. Hello, Sheila. Happy New Year to you too. I will, for just a little bit, lose the chat, but I have a backup help with me. With Jessica is here to monitor the chat. I thought it would be easier if I shared my screen. I will allow me to zoom in a little bit more to hopefully see the images on the algorithm a little bit better. So let's go ahead and get started. So again, I welcome all of you joining, and I know there's people that can't be on it. This will or is being recorded and will be available in our 360 NeuroGo premium playback space, which I'll remind you at the end of tonight's talk. So before we get started, you've already been introducing yourself in chat, and just as a reminder, I'm not able to monitor chat as I talk through this algorithm. So if something happens, just type it in chat and Jesse can let me know. Otherwise, we'll come back and answer any questions that you may have. I do want to point out on your screen, you should see on the right-hand side where it says files, and I have put in there the dizziness symptom profile. I also uploaded it before this started, so you should be able to ideally, if you don't see it in chat, because sometimes once we start chat, you don't see it, you can go to files on the right-hand side, and you can download the dizziness symptom profile. That's a really nice tool that I'll talk a little bit more about before I start talking about the algorithm. And one thing, just kind of a little bug to put in your ear is this dizziness algorithm, it may not best suit you as a clinician. So we're coming from this from all levels of experience in the vestibular space, and a little story about how this algorithm was created. We actually had, it wasn't the only patient, but it was a kind of one of those repeated stories where we had a nurse as a patient who she was actually a head nurse in an emergency department, and she had the onset of vertigo with hearing loss. And she, was triaged, diagnosed with vertigo, said, if you don't get better, go see your ENT. By the time she got into an ENT, it was, out of those ideal time frames to receive steroids for her hearing loss. And then she actually, unfortunately, she did receive steroids, but it didn't help her hearing significantly. And then she was eventually referred to our center. And she said, I just don't understand why, no one gave me steroids. She did not know about it, but, the ENT had mentioned, ideally you would have seen these, receive the steroids with the acute onset of your hearing loss. And then we talked about that too. And, I had heard that story before, so created the algorithm. really for people who may not know much about dizziness, or just actually I was asked to speak to an association of family practitioners about dizziness, because think of how many people either go to the ED or go to their primary practitioner with vertigo. And just here are a few basic questions you can ask. And here's some basic kind of clues from the history, working through an algorithm for a possible diagnosis, and then test what test may be helpful in that case scenario. So that's why this algorithm was originally created, and it ended up becoming a marketing piece in our marketing packet, which is why you see the image on the top is just a folder with we laminated the differential diagnosis algorithm. On the right hand side, we have our referral pads, which also provide explanation about vestibular diagnostics, and then we have a brochure in the clinic about the clinic. So if you are coming into this webinar with experience, you already have the skills to take that deep dive into a very investigative history and gather more information than you're going to see on this algorithm. If this is a new space for you, kind of a newbie on the block, then this is a great way to start thinking. We use this with students to start thinking about asking questions. But again, I think it's a great tool. Nurses love this. Primary care offices love the differential diagnosis algorithm. And the reason I wanted to mention the dizziness symptom profile, where you may find that beneficial, is considering that questionnaire. It was developed out of Vanderbilt University, is having your patients fill out the questionnaire, and it, based on the answers, it gives you an idea of what it might be. Is it going to be exact all the time? No. You may have someone who answers it and it suggests superior canal dehiscence, but they have vestibular migraine. But at least it's a tool that they can fill out as part of their original paperwork. And, we have people fill out the dizziness handicap inventory. We love the screen, the DHI screen, which is only 10 questions, but it's not creating a working diagnosis for us. That's basically their perceived symptoms. The dizziness symptom profile is unique, is because it creates a working diagnosis. So wanted you to have a copy of that. So let's work through this algorithm together. And are we good just with any? Okay. So I'm going to zoom in here. So this is, just a 2-page handout. And again, starting with the word dizziness, that we know is a vague term. Medications, just about every medications can cause dizziness. Even medicines for dizziness can result in dizziness. We want to, ask questions about caffeine, alcohol, nicotine intake, any history of allergies, history of migraines, any history of head trauma, whiplash, neck injuries, anxiety, depression. Was this an onset with hearing loss? So these are some basic questions. Again, for those more skilled, experienced clinician, you're already thinking of a lot more questions that you would ask. And then I love, to ask the patient to describe their dizziness without using the word dizziness. So we start with this big word, dizziness. How are we going to work down through this algorithm? So when we look over here, is the room spinning? So do they see the environment spinning, or is it a feeling in my head? So what if they say, no, I don't? Everyone asks me that. No, I don't. And do they feel like they're losing consciousness, or do they feel faint-like? No, I don't feel like I'm going to faint. I feel more unsteady. Oh, okay. So you feel more unsteady. Is it a feeling in your head? Is it more from your feet? Yes. So we think about in our head, we're not writing it down on paper. This is a thought process. We're creating a working diagnosis. And I have in parentheses the ICD-10s associated with these various diagnoses. What if they say, I don't feel like I'm going to lose my balance, but I have rocking sensations, these persistent symptoms of self-motion. Okay, so is it worse in standing, motion, busy, visual stimuli? Then we start to think, could this be 3PD? There's currently no ICD code for that. Or do they feel better when they're moving and feel worse when they're being still, or feel worse when they're lying down in bed? Then we start to wonder, could this be an MDDS, whether that is triggered by being on a boat or a plane, or what we reference as spontaneous onset MDDS. There's no known kind of prolonged passive motion that actually triggered their symptoms, and currently no ICD-10 for that, even though it's recommended. Some people will use the diagnosis of dizziness for that. So let's go back over here and think, okay, yes, the room is spinning. They have vertigo. Again, we know that word by itself doesn't help us much, but it is, has a diagnosis code. Is this episodic? Yes, it's episodic. Okay, it lasts seconds and it's positional. Once again, for the more experienced clinician that may be listening to this, you already are kind of creating that working diagnosis, but people not familiar with how to, ask directed questions, this type of algorithm can be helpful. So there's different diagnosis codes for the different types of BPPV. So H8111, we have right, we have left, and we have for both. And here what we're thinking is doing a Dix-Hallpike and a roll test. But not just that. We also, when we suspect BPPV, we want to be testing someone's balance. We want to be testing gait. Maybe you have access to posturography testing. So we're not just going to do the assessment for BPPV, primarily in the vestibular rehab setting. We're not going to. Certainly at a physician's office or PAs or nurse practitioner's office, they may just want to do that testing. But I like to encourage people to look at positional testing as well. We don't really think about a V&G if someone hasn't had it and they're coming to us with these signs and symptoms suggestive of BPPV. Now, if it's complicated, and certainly this is not by the book, a general rule of thumb, kind of 3 strikes and you're out. If someone's coming and, it's their 4th visit with me it's not resolving, I'm starting to get a little worried that I'm missing something, because I'm probably most likely doing multiple treatments in that one session if they can tolerate it. So which means I've tried multiple maneuvers. And so if someone comes in and they've said, I've had the maneuver 9 times for BPPV, certainly I'm going to test them. And if I don't see classic findings, then I'm going to recommend a V&G because I'm thinking we're missing something. So let's move back up and we say, okay, episodic vertigo. No, it's just kind of constant. It's there all the time, 24/7. Or is it related to head movement? Is it not related to head movement? We're certainly, recommending a referral to vestibular rehab. Keep in mind, again, that this algorithm was written for other healthcare providers who did not have or had little experience around, dizziness. Because we know that this can come back around as this 3PD and obviously we're not forgetting about the red flags. Let's say it's episodic, but it's minutes to hours. Okay, so then when we think, yes, it's minutes to hours, is this with hearing loss? So someone's having spells for 20, 30 minutes, up to hours, maybe even a day. Then they have hearing loss with it. We're concerned that there may be, Meniere's disease, or is there a vestibular migraine? And what tests? Audiogram is going to be a big differential in vestibular migraine versus Meniere's. Now, we know there's a crossover, right? That it's predicted that maybe a third of the population has vestibular migraine and Meniere's. And so that's a very complicated question to address, but we always go back to that audiogram and look, if it's Meniere's, then we would expect to see that low frequency sensory neural hearing loss going down. We don't expect to see the low frequency associated with vestibular migraines. We can get clues from kind of, serial testing of audiograms associated with their spells. V&G can be very helpful. For Meniere's disease, ECOG is helpful in identifying fluid problems of the inner ear. Again, we go back where we also want to be testing balance. Vestibular migraine, those tests can be beneficial as well. VIMPs are starting to show more promise about certain patterns associated with vestibular migraine. Certainly, VOR testing with either Meniere's or vestibular migraines, balance testing. And then, you see VRT or vestibular rehab therapy indicated if this patient is stable. Now, if they're fluctuating in and out of spells, they're not controlled, then they may not be the most appropriate for vestibular rehab unless it's patient education, but not coming back in for repeated visits until they're somewhat stabilized. So we'll go back up, and so it's minutes to hours. Yes, sensitive to noise and pressure changes. Is there a superior canal dehiscence? Again, we come back sensitivity to pressure changes with some hearing loss, then we may be looking more at a paralymphatic fistula. For the more skilled clinician, we know that there's crossover in here. What becomes more important, again, comes back to that audiogram, because a hearing test with superior canal dehiscence is going to be different than a hearing test with paralymphatic fistula. For those of you who are premium members in the 360 NeuroGo, we actually are introducing, we have vestibular diagnostic testing in there, and part of that is these brief videos on the different hearing patterns. I also have a more comprehensive talk on the value of audiograms, what it looks like with Meniere's, what it looks like with superior canal dehiscence, what it may look like with paralymphatic fistula or a labyrinthitis. So audiograms are so important. It's, if someone wanted to take, we're lucky here in the clinic, we have this full vestibular diagnostics provided by an audiologist. But if someone came in and said, we have to take that, we have to get rid of all that, what's the one test you want? It would be, I couldn't imagine not having an audiogram. Certainly, patients can go to many places to get ideally good comprehensive hearing tests. I think getting a good comprehensive hearing test is one of the bigger challenges. Sometimes, especially in something like superior canal dehiscence, where they may start to test their hearing and it looks normal, so they stop the test. They don't do air bone gaps, and they don't do temps, they don't do reflexes, and so that is problematic, right? We're missing information if we don't get that full comprehensive audio. Here also on superior canal dehiscence, you'll see where I have closed glottis valsalva. That's nice to do with wearing Frenzel lenses or the video goggles. Also in the 360 NeuroGo, you have access to an article that recommends doing the closed glottis valsalva in the supine position, that we may miss positive findings and sitting, but see them in supine. And I have actually witnessed that myself. And what was interesting is I originally did the test in sitting, and then their findings of their audio and their VIMP looked like a superior canal dehiscence, and it it did sound like superior canal dehiscence. I came across this article, can't believe it was the first time I've ever seen it. It was in a kind of an obscure journal, and then repeated it supine and actually saw the nystagmus with the closed glottis Valsalva test when doing it supine. Certainly, a high-resolution CT scan of the temporal bone is going to be the most confirming, and that's where you for superior canal dehiscence, and that's where you see temporal HRCT. So these abbreviations are explained below in that key for abbreviations. So we come back to this episodic vertigo, seconds, positional, minutes to hours. No, it's hours to days. Some patients will report it even last weeks. Was that with hearing loss? If it's with hearing loss, it's considered a labyrinthitis. If it's not, it's a neuronitis. Now, when I think about this algorithm, when I look at it, every time I talk about it, I think about what it's missing. You know, we know ischemic events can mimic labyrinthitis and neuronitis. So ideally, this algorithm would also, with the acute onset of vertigo, be recommending the HINTS test in the acute onset of vertigo. So we see these terms used interchangeably. You may get someone that comes into your clinic diagnosed with labyrinthitis, but they have no hearing loss. That's really a vestibular neuritis, and the audiogram is key. V&G can test, further test peripheral vestibular by identifying spontaneous nystagmus. Where are they at in the neural recovery process? VIMPs can be helpful for otolith function, VOR testing, and balance testing. So this, again, is a basic for the more skilled clinician. You are going to be asking more questions than this. We know this isn't etched in stone. These aren't all the diagnosis, but a great starting point. I think that you can utilize this tool with other healthcare professionals that are looking for more information on tests they can do. So let me go here and exit out, and then I'll move on to the next slide. Obviously, I'm not going to read this one, nor are you going to be able to read it. But on the back side of this handout, it has some stats. It talks about the HINTS test, has a couple of references, and then it goes over the more common types of vestibular disorders. These are very brief explanations: acoustic neuroma, BPPV, general vestibular dysfunction, MDDS, Meniere's disease, migraine. Moving more towards vestibular migraine versus migraine-associated vertigo, paralymphatic fistula, 3PD, superior canal dehiscence, vestibular labyrinthitis or neuritis. And then, on here, there's actually, we do have a handout. I realize the back of this has an added one at the bottom, and believe me, it was hard to squeeze it in, is vestibular paroxysmia. And that is a diagnosis that is currently not on this algorithm, and that's where someone may have repeated spells of vertigo. If we go back here and zoom in again and think we're going to go episodic vertigo, seconds, like they may have 30 spells a day, and there's no warning. They can happen in sitting and standing. They're like they're seconds, and that is vestibular paroxysmia. So that's just another diagnosis that could be added to this algorithm. And what I would love for you to do is think about, when you have time to go back, look at the algorithm, and we can find better ways to expand on this. When I started this, I did not have 3PD or MDDS on it. I actually had one over here that was more about potentially anxiety. And then, 3PD and MDS we've had so much more awareness around it that I added that. So I think vestibular paroxysmia would be a good potential diagnosis to add on, definitely on this page. And so when this is our closing slide, and then so I was given a question here. Can you speak to the physiology of the supine testing versus the seated testing for superior canal dehiscence? Yes, and I can provide you with the article as well. But it is thought in the seated position that we could actually, where the superior canal dehiscence, that opening, is there can be enough pressure to actually close that gap and not get the response that were needed. And that space opens up in the supine position. So it's really a nice article. I think the lead author on it was Carrie Hops, physical therapist in the military in San Antonio, Texas. So I'll make sure that everyone has access to that article, because we have changed here in the clinic the way that we do the closed glottis testing. And again, in the 360 NeuroGo app, for those of you that are premium members, when you go to vestibular assessments, I had created that space before I found this article, but when the video was made. And so you see the video being done in the seated position, but I've added a disclaimer on that, that it's actually recommended to do supine, and you can access the article there. So the way those spaces work in Vestibular Go, you go to assessments, it has the closed glottis Valsalva test, and there's a video that tells you how to do it. A disclaimer of the newer research indicates to do this supine, and then it has a link to the article there. So this is really the closing slide, and then I'm going to stop sharing my screen so I can see the chats and we can continue the conversation. Is we come from all kinds of experience. There's, an entry level, an intermediate. You may feel, more of an expert in your field, advanced. I don't really know what advanced plus is. I just lifetime learning. There's nothing that defines these. This is more where you see yourself. So in 360 Neurohealth, we provide education as in these areas at an intro level, at what we think is an intermediate kind of practical strategies, and then the more advanced, we have our certificate of competency in vestibular rehab course, and then we're this year offering our advanced clinical decision making, and that's a course where you either have a certificate of competency, or if you don't, you show that you have an advanced training, and you can see if that you apply to come to that, if that meets the requirements to attend the course. And it's not a certificate course. It is clinical decision making, problem solving, complicated case studies, working together to create more sophisticated algorithms and what we call heuristics. And heuristics is a pretty controversial term in medicine. It's used in psychology, where you find shortcuts to get clues to go here. But it's science. We're talking about science-based, right? We're not talking about shortcuts just to not think. We're talking about creating heuristics based on high-level clinical decision making. And so it's the advanced courses. It's 5 weeks online. You have homework, and then we have a live lab. It can also be attended virtually, and people will work in groups to work through complicated case studies and then present to an expert panel. So it's really a time to collaborate, work together. And some of that's even going to bring in the challenges associated with anxiety, chronic depression, and how that affects our sympathetic nervous system, and how that affects our test findings and our treatment plans. So it's not not just vestibular-related tests and treatment. So I'd like to stop sharing my screen and get back to seeing what questions you may have. All right, I'm back in a virtual room where it's a lot of light coming in. And yes, could you possibly speak to the effectiveness of VRT in Meniere's, specifically if there's evidence that VRT can reduce the frequency of severity of Meniere's episodes? Gosh, what a great question. And welcome other people to share your opinions. There's so many skilled clinicians that on tonight's talk. So thank you for that. What we look at Meniere's, if someone comes in with a diagnosis of Meniere's, and we find that in between those episodes that they are recovering. So someone may have been referred and they're like, I don't know why I'm here. I'm good today. You're not going to find anything. And so, but that's a great patient education topic of where we can use that to, ask them more about, do they have any warning signs? What's their sleep patterns? What's their diet? Is this potentially being influenced by a gut to brain? What's their sympathetic nervous system? What's their visual system? Can we reduce visually induced dizziness, visual motion sensitivity that might reduce their, I don't like to use the word trigger, but so I'll use it with you. I try to avoid that word with patients because I don't want them to live in a life where they think the grocery store is a trigger, so I'm never going to the grocery store. What kind of activities increase their symptoms? So yes, I do. It's a great question that I will look up. I've looked in the literature before about the reduction, and I don't recall anything but there may be something more recently, or someone on the webinar here may know of some specific research that does show a reduced recurrence of spells. What I do find, or like what we do find with patients, if we have someone with vestibular migraines and they have BPPV and we treat are having BPPV, not just, but having BPPV, we treat them. Sometimes that treatment triggers a vestibular migraine. So in my mind, I like to tell myself, as we reduce their sensitivity to visual stimulation, as we reduce their rapid head movements, as we ensure optimal posture, optimal cervical range of motion, cervical kinesthetics, that we could potentially reduce spells. And I've heard that symptom report of dizziness from older adults can be more subdued. Do you find this to be accurate, and does this affect accurate diagnosis? It's a great question, and it's great to see your name on this. Yes, the literature does show that. There's actually a growing amount of literature. When I went to the American Balance Society's meeting, which is always held in Arizona, it's actually it's research based, and so all the researchers go. There was quite a bit of research in older adults on not being able to identify how far they were being tilted. So they had to be tilted pretty significantly before they realized they weren't in the middle, and that group had a higher risk of falls. So there's research being looked at right now, and we're actually fortunate to be a part of that research, is looking at ocular counter rolls. So when you tilt someone here, and then I'm using the goggle subjective visual vertical test, where I'm looking at SVV, so the ocular tilt response with the head in neutral, with it 15 degrees and 30 degrees. You can also do 45 degrees, but I don't find people can really hold very well that 45-degree tilt. So I do 0, 15, and 30. And that's actually for those of you who might use the bucket test for the subjective visual vertical, which is a nice, it's a recognized test for otolith function, is not just doing it just with the head in primary, gaze, but have them tilt the head 15, and on the back of the bucket, you know their head's in 15 degrees rotation because you have the measurement on the back of the bucket. And then doing it again in 30 and more than a 3-degree difference is considered abnormal. So yes, on knowing where I am in space, how far I'm tilted from midline, it's also suspected that as we age, we have changes. We have age-related changes of the inner ear, and those changes are gradual. And so because they're gradual, people don't identify them. They don't identify that they're dizzy. They don't identify that they have balance issues versus someone who comes in with the acute onset of vertigo and they have sudden loss. They're very well aware. But if it happens over time, and that can even happen with Meniere's, where as their Meniere's progresses, not everyone has vestibular loss function with Meniere's. They have progressive hearing loss, but maybe their vestibular system recovers in between the attacks. For those that it doesn't, that it gets weaker and weaker, they kind of burn out of their Meniere's because they no longer have function. That asymmetry is no longer there. Versus if you have someone with uncontrolled Meniere's, but they have good vestibular function and suddenly get gentamicin injections to destroy the ear, they're pretty miserable. They're pretty surprised about how they feel bad every day. They don't have the spells, but suddenly they went from having vestibular function to no vestibular function. So that can be quite surprising in patients if they're not aware of that process. And then as far as BPPV, I think I'll add another note on that, is it is recommended, the APTA guidelines recommend that in those 50 and older to assess BPPV because